text include all the references I wanted to. But the basketball games over the weekend kind of got in the way, unfortunately. Anyway, I thought I'd talk about sepsis and septic shock, but try and put in the clinical context for everybody. Let me see if I can figure this out. And these are all, there's always this cartoon in the beginning that wants us to talk about mortality rates in sepsis, and they've come down in the last 30 years. That graph is, in fact, up until the year 2000, and then it kind of leveled off and it stayed there. And so it's led to a number of initiatives and campaign deriving sepsis. And I'm sure you're all familiar with that, and the ventilator bundles and save 5 million lives. We're trying not to kill 10 million on the way to that goal, but I hope I introduce a little cynicism in all of you for some of these processes, even though we are obligated oftentimes to follow. But the mortality rates have dropped compared to what they were back in the 70s and 80s, and that's partly a reason, partly because of the epidemiology of sepsis has changed. And we'll talk a lot more about that. But first, we got to do some definitions. So there's some easy gimmies in these true and false questions. Can you see the screen okay, Robin?
Yeah.
Can you see it?
I can see it. I can't read it.
Can't read it now. You know, I would have broken this down, but I just wanted to use this as sort of a touchstone to review some simple definitions. The first is that there's a simple definition that didn't get into the ICD-9 code book until a year or two ago. And the fundamental necessary condition that predisposes or precedes sepsis is a condition known as the systemic inflammatory response syndrome. That's abbreviated SIRS. Is everybody familiar with that? That's a criteria that's used clinically and used in regulatory agencies throughout the government, not just Medicare and Medicaid, but reimbursement situations. It's also used by the FDA in clinical research. So these are kind of basic fundamental criteria that for the diagnosis of a systemic inflammatory response syndrome, you have to have 2 or more of the following: either a fever or hypothermia on 38.5 degrees centigrade or less than 35, heart rate greater than 90, respiratory rate of 20. You're familiar with these. A PCO2 or less than 32, white count of greater than 12,000 or less than 4,000, or greater than 10% immature bands. So you can have a normal white count and have 20% bands. And I think, I don't know if not all of you were here last time, but we talked a little bit about what that reflects. You remember what bands mean? Anybody got a rough idea? Can you remember what I said? No. Hell, I can hardly remember. Let me pick a wild. Let's pick a lab person. Where's the student? Oh, there you are. Yeah. Well, they're back to me. Good move. Well, remember, we talked about that. That means a premature release of immature forms from the bone marrow. So that means there's a lot of stress. You can have a normal white count and high bands, and that's as significant as a white count of 16 or 20,000. You can have a white count of 8,000, 20% bands. That means the same thing in terms of the diagnosis of systemic inflammatory response. Remember, there's lots of times with patients on steroids, either before they come in or they get them right after they come in, because they get a lot of things right after they come in that I've never quite understood with the, they're slamming antibiotics and steroids. And sometimes that's because of the urgency, but sometimes I'm a little confused by it. So you want to know when the white count was drawn in relationship to outpatient corticosteroids that day or IV steroids in the ER. Because circulating white cells are measured with a CBC you draw, but the total number of white cells, and we talked about this, so if I'm repeating myself, I'm trying to catch everybody up. Total number of white cells in the circulation is twice what you see on the draw. And when you give steroids, the white cells that are marginated, which are attached to the endothelium, waiting for a signal from the tissue to migrate, are all released into circulation. So steroids detach the marginated white cells. So that's why your white count goes up, but your bands should not go up. They do not stimulate steroids don't stimulate premature release of white cells, so you don't get immature white cell forms because of steroids. I don't know, how well does our CDC, what's the level of sophistication? There's some function of an automated CBC that tells you the percent bands now? Is that right? Or do you still have to do a peripheral smear? Pretty much still have to do a peripheral smear. I thought some of the newer machines were getting a little more sophisticated. But if you don't ask for a manual diff, then here, you're not going to get a measure of bands. So those are important because sometimes patients come in with subtle signs and symptoms. So we'll talk about that and we'll have a lot of cases with you. The next step up in this cascade or this ascending table, in descending fashion on the table of severity is sepsis itself, which occurs in response to a documented infection. And that documented infection is an important criteria. You don't have to have microbiologic confirmation, but you have to have a clinical suspicion, either a focus of infection identified by visual inspection or a ruptured bowel, something obvious like a perforated colon from diverticulitis, wound with a pussy discharge and a lot of tonsil and erythema. And we'll talk more about that when we do the skin and soft tissue, but really most skin and soft tissue infections that are going to cause sepsis usually are at least 75 square centimeters or more in diameter. And you say, where the hell did you come up with that? Well, that's all in a lot of older data that was done in the 50s and 60s. And recently, with the advent of resistant organisms and the need for newer antibiotics, the FDA has had to go back and redefine what a skin and soft tissue infection is and what effective therapy is. They actually have gotten very frustrated because what the FDA would really like us to do are placebo-controlled trials. That's their mindset. Well, nobody's going to do that ethically in this day and age. But they would still like it because ethics sometimes isn't always in their playbook. But anyway, what they had to do was go back and find the study that was done. It was done in, I think, 1939, where they looked at the treatment of erysipelas. And they measured the square inches, square centimeter in the area of confluent infection of erysipelas, which is usually group A strep, classically on the face. And they looked at the use of one of the sulfa drugs against phototherapy. They used ultraviolet light. And the FDA decided that was probably as good as it gets for placebo. You can't tan to cure your cellulitis. So they actually went back and extracted out of hundreds of cases that were submitted back in the 30s and 40s and looked at criteria. And it's interesting that they found that the square centimeter area for skin and soft tissue was 75 centimeters for a significant cellulitis that would not spontaneously abate on its own without an antibiotic intervention. And they found that temperature of greater than 38.5 degrees or less than 3, all these numbers are actually popped back up when we refute that. Heart rate of greater than 90, glycon elevated over 12,000 or less than 4,000. Very interesting. Because systemic inflammatory response syndrome is usually a cellulitis that will trigger that requires antibiotic therapy. If you have a cellulitis that's only 5 centimeters or 10 centimeters in diameter, a significant number of them will spontaneously abate, believe it. So there are certain size criteria for documenting an underlying infection. And I just wanted to talk a little bit about skin and soft tissue since we see that more than we used to. There's obviously other foci like pneumonia that are common, foci like perforated bowels, gangrenous gallbladders, and all those other things. What distinguishes sepsis from severe sepsis is signs of organ dysfunction or hypoperfusion, areas of mild skin, prolonged delayed capillary filling, low urine output, mental confusion, confirmed sometimes or rarely by abnormal EEG foundations, and platelet count less than 100. That makes sense. That's this is one we'll emphasize a little bit. Obviously, if the patient has DIC and ARDS and has to be ventilated immediately, you're not arguing about whether it's severe or not. Not arguing. The platelet count of 100,000 is very interesting. If the patient presents a very fulminant infection that's rapid, in other words, the bacteria are multiplying rapidly either in the bloodstream or in the skin or in the abdomen, intra-abdominal space, sometimes the platelet count's normal when they come in. So how many days does it take for it to respond to the initial sepsis, the initial cytokine injury, which we'll talk about? What's the natural history of thrombocytopenia and sepsis? Patient comes in, I just got sick this morning, rapidly ill, gets a white count. White count's elevated, platelet count's 140,000. When do you think, how many days will it take for that initial injury and the process that leads to thrombocytopenia to develop, you know? Up to, somebody said 3 days. So, when the white count goes to 100,000 the next day, and then 60,000 the third day, it's not from the flippin' low dose enoxaparin they got on admission. And if you're focusing on that, you don't understand that that patient has developed severe sepsis. And that's a misdirection I see all the time. Suddenly, you know, they grab the pharmacy student, make him look up all the drugs that he got in the last 2 days. I mean, he flies like a duck, quacks like a duck, and walks like a duck. It's a duck. It takes sometimes up to 3 days for thrombocytopenia from the initial septic insult to evolve. So if you see somebody tunneling in on thrombocytopenia on the third hospital day, they're not focused, or they need to back up a little bit and look from a higher altitude, because that's part of sepsis shock. The most common cause of isolated thrombocytopenia in hospitalized patients in the ICU is sepsis. But Jim Heffley still gets consulted way more often than I do. For why is that platelet count low? I'm not kidding. I don't get consults from the primaries often with thrombocytopenia. I get them from Jim Heffley because he said, well, they asked me to see this patient's white count 60,000 on the second or third day. And he said, I'm sure it's sepsis because he was admitted with pneumonia. It isn't from the enoxaparin. It isn't some exotic diagnosis. It's part of this whole spectrum. That's just, obviously I have a pet peeve, that's one. I like talking to Dr. Heffley. I don't mind getting those calls. Septic shock is separated by hypotension, where the mean blood pressure is systemic blood pressure less than 60, and less than 80 if they've been hypotensive prior to that. After fluid resuscitation, that's 40 to 60 mLs of saline or lactated ringers. That's it. Okay. After that, that's it. You don't give it and then give more. You can drown. You don't want to drown. And back when we used to use Swan gas catheters, they included the definition of capillary widths between 12 and 20, which just meant that they had normal filling pressures. So they normalized filling pressures. It's still hypotensive. That's septic shock. That's different than severe sepsis, which represents, you know, is represented by reduced urine output with or without an immediate increase in creatinine. But you can have a normal creatinine and drop your urine output. If you tied off the renal arteries, how fast can the creatinine increase in the next 24 hours? Do you guys know? If you just tied them off, it can't do more than double. So even with absolutely no renal blood flow, the creatinine may not, just like the platelet count, it takes a couple of days to see the effect of the original insult. So a climbing creatinine at day 2 or 3 doesn't mean that what you're doing is failing. It means it's evolving from the initial shock. And to simplify it for patients, families, and to lay people, and they don't understand why, you know, mom looks sicker on their third hospital day, you're trying to tell them, anticipate that they're going to feel. If you're lucky, they won't, but sometimes they evolve. Warn them that it'll take 72 hours for the worst, for them to hit bottom. And I tell them it's a lot like getting hammered, and getting a blow to your leg and having subcutaneous hematoma. You won't. It doesn't turn black and blue for a day. It doesn't turn yellow for 3 or 4 days. It only took that original injury, and then it takes days for the signs and the final effects to evolve. That's kind of a simple analogy that I use for patients' families. It sometimes helps them get through those first couple of days when everything's going to hell in the handbasket. Refractory shock in this definition is interesting, different than it used to be. need for dopamine at greater than 15 mics per kilogram per minute, or norepinephrine or epinephrine greater than 0.25 mics per kilo per minute to maintain a mean average blood pressure greater than 60. A MAP, mean average blood pressure greater than 60. Refractory shock used to mean that they still needed vasopressors after 3 days. But that's been changed to just the absolute requirement for it. You don't have to wait 3 days to make the diagnosis of refractory shock. So what's happened in a number of cases? This is, I hate to date this. Ha! This is when I was a fellow in infectious diseases. The interesting thing about this graph, this is the incidence of sepsis according to causative organism, whether it's gram-positive or gram-negative, since the early 80s to the year 2001. And when I was in training, there were more cases of gram-negative sepsis than there were gram-positive sepsis. Any idea why that is? What do you think changed between here and this critical point? What is this, 1988? When the number of gram-positives superseded the number of gram-negatives. What happened in the pharmaceutical world? I'll give you a hint. No. In this case, probably not. That's a good thought, but that's a little, resistance is always happening. You're always right, actually, when you say that, so that's a good answer. You're always right. We'll talk about that later. Drives me crazy to talk, well, we'll talk about it. What, I think you got it. The introduction of gram-negative antibiotics. What happened here was the introduction in the early 80s when this started to plateau off, was the introduction of cefotaxime and then ceftriaxone. And then the quinolones. Linda's right. That's about when ciprofloxacin and levofloxacin increased in use. And so they've sort of plateaued in the last part of the 90s, and they've started to increase now, especially because of resistance. And there hasn't been a new antibiotic class introduced for gram-negatives in quite some time. Because there's more money in gram-positive. If there are more patients, there's more money. And this is not just true for sepsis, but even more so true for community-acquired pneumonia, skin and soft tissue infections especially. We'll talk more about that. This is an interesting graph because this is where the rate of gram-negatives slowed, and then the quinolones really made a huge difference. So what is it? Why are quinolones better than cell wall active agents? Anybody have an idea? Is there a pharmacist who wants to answer this? Dave? It's not fair if I cannot. Outpatient pharmacists. They have a rough idea. Bactericide, God, so if you read the questions. Because they have concentration-dependent killing. So you can dose them once a day, and it's as effective. But with cell wall active agents, penicillin, cephalosporins, the level in the bloodstream has to be above the MIC for at least 40% of the interval between dosing. So you have to dose them more, and there were a lot more mistakes made. And quinolones sort of took us off the hook. And most of us that didn't understand pharmacokinetics got off the hook when quinolones were introduced, which is probably 90% of the medical profession in terms of being weak on PKs. And this other interesting that happened, this has continued to climb up, is the advent of fungemia. Do you have any idea why that is? Usually, primarily candidemia. Yeah, what's that? Neuroflora, and then the immunosuppression. Both those things are true. So we see more central line infections, especially in the late 90s before we got into better practices here from central line infections. And then there was an increased incidence of intra-abdominal infections because we had great antibiotics, but if you didn't control the source, there was still, say, a diverticular leak. If you killed off the bacteria, what's left? You can't. So this was partly because of the success of the antibiotics that were introduced here that dropped the gram-negative zone. But everybody knows, backing up a little bit, that gram-positives include strep and staph. All right, because I didn't want to go back to basic gram stains. Unless you want me to, I can do it. And gram-negatives are usually E. coli, Klebsiella, and So you have to evaluate for the common source. And this is something that can happen, oftentimes has to happen really fast, and sometimes it's easy in the ER, and sometimes it's not. And one of the, we'll talk about that. They include upper respiratory tract here, and we'll get back to that at the very end of the talk. But this would be an unusual but very important to recognize cause of sepsis. In general, though, pharyngeal inflammation with exudate and lymphadenopathy are not going to precipitate a septic syndrome unless you're immunosuppressed. If you have neutropenia and you still can generate exudate in your posterior pharynx, you're in deep trouble. But outside of neutropenic patients, this would be an unusual focus. And since we're talking about our experience here primarily, I'll emphasize that. I will go into that at the end. Lower respiratory tract, this is probably the most common cause of sepsis that we see is community-acquired pneumonia. So what's the most common cause of that? By far, hands down, strep pneumonia, yeah. The problem we've had with strep pneumonia in terms of resistance is there's more intermediate penicillin-resistant strep pneumonia, which means we can't use plain penicillin-like drugs anymore. We have to use, anybody got a rough idea? I mean, why it's on the hospital-acquired, community-acquired pneumonia protocols. Ceftriaxone, because it's more active than penicillin for those intermediate resistance. We have not seen invasive, highly resistant strep pneumonia. We've seen more highly resistant strep pneumonia, and I think Connie can correct me, but do you have any, you want to take a wild guess as to what the percent of strep pneumonia in the last year or two has been that has been highly penicillin resistant, has been isolated in the lab? Somebody want to take a wild guess, Michelle? Remember, you can usually, when somebody's asking for a percent, it's either 0, 20, 80. And you're so close if you say 20 of it. This is a good gimmick. I think the last one, or the one the year before, was up to 14%. The trick was in those that they weren't highly invasive. These weren't blood culture isolates. A lot of them were sputum isolates. And they can't, that has not translated into failure of our pneumonia protocol with ceftriaxone and azithromycin. That's something we have to watch. It's really hard to pick apart those isolates from invasive isolates, and I guess because you only see a positive blood culture in severe strep pneumonia in maybe 10% of patients, even with sepsis, you'll only get 1 out of 10 with a positive blood culture. We don't have good ways of deciding that retrospectively in terms of infection control and going back and looking. With MRSA, it's a completely different story. As soon as the percent methicillin resistance hit 5%, every hospital was medical legally and ethically, you had to switch to empiric vancomycin. And you guys remember that about 7 or 10 years ago. But that 5% threshold hasn't been true for highly pen-resistant strep pneumonia. Okay, so we have to watch that because it could become true. So resistance doesn't always correlate with virulence. It does with MRSA, it does not with strep pneumonia. They're all fairly virulent. Some are more sensitive than others. But this lower respiratory tract, by far, is probably, in our experience, the most common cause of sepsis that we see in the ICU. There's a guy up there now. Urinary tract, this is pretty common. Problems we have with these patients when they present is, I don't know anybody over 50 that doesn't seem to have white cells of 50 in their urine. Men get it because they have obstructive uropathy from prostatic enlargement. Women get it because they have incomplete emptying of the bladder, sometimes because they've had multiple children, they've had a hysterectomy, and then with incomplete emptying, you get bacteriuria and you can get asymptomatic pyuria. But that does not equal, unless they're symptomatic, that doesn't predicate treatment. And this leads to a lot of misdirection because the ER doesn't have a chance to sort this out. They've got to treat what they see. And we'll talk a little bit more about how we're pressured into that. But seeing an elevated white count in the urine on the UA in the ER, and you're not going to get the culture, remember, till the next day. It really has to be taken with a note of caution. You want to find out if the patient's been symptomatic. Older patients that are confused on something, can't tell you if they've had burning. The fact that the urine smells bad isn't a criteria for antibiotic use, but it seems to be in most of the nursing homes. That's usually what you get called with. Her urine smells bad, so I got a UA. And it has a lot of white cells, so we need an antibiotic. Does she have a fever? No. Is she confused? No. Is she complaining of burning? No. She have flank pain? No. It's asymptomatic pyorrhea, so you can't get too worked up about that. You have to put it in the context, clinically, of the source. So this is where we get misdirected a lot. And sometimes, especially with mental status changes, you've got to treat empirically and then back off later. But this leads to a lot of concern because oftentimes, especially in places indwelling Foley's, they're always colonized. And we have to expand, especially from skilled nursing facilities or so on. We have to expand coverage because they're more likely to have resistant bacteria. So it leads to a lot of expanded spectrum antibiotic use, this single event. But take it with a grain of salt, and always clinically you have to go back every day and see, is this really a UTI? Or did they have a pneumonia that was missed on the chest x-ray? And the ER doesn't have time to sort this out. This stuff has to happen. They have to make a decision to treat, and should make a decision to treat, but don't hold the ER to task if the next morning the chest x-ray is more obvious or somebody picks up the fact. They can't be expected to do that. That's not their job. That's the job of people taking care of them in the ICU. Yeah?
You know, it seems to me that a lot of times when a patient is really dehydrated, the chest x-ray doesn't look that bad. But once we get him a little hydrated, or 24 hours later, you'll do another chest x-ray and it just looks like whiteout.
That's a very good point. She's a plant. She has other. And that's exactly what happens. You get delayed appearance of pneumonia. Wound and burn infections, if we can get the surgeons to admit it, or sometimes report, okay. Skin and soft tissue infections, we talked about that. This is a little outdated. This says culture blister fluid, role of vascular, it's not proven. Now the FDA, the standard of care is recommended is if you have the availability of the tools. Sometimes Central Supply does, sometimes I go to the office, do a 5mm punch biopsy of the skin. You get about a 20–30% yield on the pathogens, where if you aspirate it, you're lucky to get 1 out of 20 or 1 out of 30. Usually you don't get it. But a 5mm punch biopsy has replaced just blind aspirates at the leading edge of lymphangitis. And obviously in the CNS, signs of meningeal irritation are important, stiff neck, and a low threshold doing LPs. Now, this is the time of year we have to have the lowest threshold. And it's been a while since we had a meningococcal isolate, but there's a 5-month-old admitted over the weekend with a positive blood culture for Neisseria meningitis. This is a classic time to see that. Do you know why? Kelly, take a wild guess. It's post-influenza. What happens after influenza and RSV is the rate of colonization of invasive pathogens, strep, pneumo, and Neisseria go way up. So, 1992, we had an epidemic. A lot of you are too young to remember that. But there are 11 cases of Neisseria meningitis. It was type C, which is the epidemic type. Type B is the sporadic type. It's bad if you see it. You have to have a high threshold, but you're not going to see a wave. In 1992, we had a wave. And my hero of that whole epidemic was George Milford. Lab won't like to hear this, but they did an LP on a 16-year-old gal that came in with a fever and a stiff neck. The fluid was clear. There was one white cell. And he made them do a diff, which isn't the standard. And it was 1 neutrophil. And in 8 hours, that culture was positive. That organism can replicate so fast in the CSF. It can replicate so fast. If it grows in 8 hours, it probably started out at 10 to the 4th, 10 to the 6th, or maybe higher. can be high as 10 to the 8 per ml of spinal fluid. It can, that's how fast it grows. It can outstrip the response in the CSF. In the post-influenza period, especially if you know you have an isolate in the community, this has to be a really low, you have to have an extremely low threshold for doing a lumbar puncture, and I think our ER does a great job. The problem we have is that it's never as simple as seeing a lot of white cells. Sometimes you see a mix of neutrophils and lymphocytes. If it's pure lymphocytes, it's more likely to be viral. We'll talk more about this when we do meningitis. The quickest test you can do in somebody that doesn't have a history of prior antibiotics on the CSF is a CRP in the spinal fluid. If it's less than 1, you are not obligated to treat for 48 hours. High-dose vancomycin is ceftriaxone. Now, having said that, in this situation where we have a documented community-acquired Neisseria meningitis, I treat him anyway. Does that make sense to you? You have to understand the epidemiology of what you're doing. If we had a PCR machine, you could do an enteroviral PCR. If that was positive, you could send them home. I talked to that doc who's the head of the Colorado IDSA Society. He said one of the hospitals had PCR for enterovirus in the spinal fluid, and after a year they got rid of it because all the people that were getting admitted with viral meningitis for 2 days usually were young and had a good insurance, and so they were losing too much revenue. And that was just, they got rid of the PCR machine. That may be a little too cynical. It would be, there are hospitals that have that. Bozeman has it. I mean, we just didn't get in the capital budget in time before all the now Bozeman wouldn't get it if they had to apply for it now, because those things are expensive and healthcare costs are shot up. But unfortunately, in that little window, we didn't get that machine, and that would have been that's a very helpful thing in the ER because it's rapid, 20 minutes. For a GI source in a patient with diarrhea, pretty unusual to see sepsis with pure Salmonella Shigella. We had one patient about 5 years ago with Salmonella typhimurium, had positive blood cultures. So it was sort of a pseudo-typhoid fever, but that one is really tough with abdominal pain, distension, because in older folks you don't know if it's what? Diverticulitis or vascular ischemia. I mean, these are very tough patients, especially with the diarrhea. It could be, for anybody who's here last week, C. diff, yeah. And then it's a very different treatment. That C. diff, fulminant C. diff can be often gets treated as sepsis, and probably should be until you get a report. Intra-abdominal infections are a little easier to pick up, except in older folks that are confused. And then obviously if you're a peritoneal dialysis patient, those patients are quickly shipped to the zoo, so we won't talk about that. It's pretty rare for genital tract infections to cause sepsis, almost unheard of, unless it's during pregnancy and they get amnionitis, chorioamnionitis. And then it can be fulminant and very aggressive. I think the last patient we had with that this was the classic puerperal sepsis. It dates back 100 years, led to the introduction of hand washing. You guys know what bug that was. We still had a patient with that a few years ago. It's hard to believe it still happens. You know what organism? Gram-positive? Take a wild guess. No, not Listeria. Listeria could do it, but it wouldn't give you fulminant. It's uncommon. Any idea? Oh, come on, you guys. This is like...
We call childbed fever.
Yeah.
That's not...
And that's what is the most common cause of perinatal mortality, and maternal and infant. Group A strep. Yeah, it's a group A strep. That's the classic puerperal sepsis. That's when somebody figured out if you washed your hands, the moms and the kids didn't die. Huh? Yeah. I just don't want to get too esoteric. But it's pretty classic and pretty important. And obviously there's still some countries less developed that haven't made that leap yet. But even with that, it still can happen. You get an invasive bug. That's where a virulent bug causes more trouble. And then there's some non-infectious mimics of sepsis. Acute myocardial infarction is kind of a stretch, unless it's during the influenza season. Acute influenza is a common cause of the bump in acute MIs. If you watch the incidence of acute MIs hospitals. The incidence of influenza peaks, and the rate of acute MIs follows it within a week afterwards. So patients come in with a fever and have a positive influenza swab and sore throat and cough. And if they have a hint of chest pain, or even if they don't, if they're diabetic, for instance, you want to get an EKG at least, because it's not uncommon for an MI to sneak in underneath that. And then with cardiogenic shock and fever from the flu, you might mistake and might get misdirected to thinking it's bacterial sepsis. So you don't want that to happen. Acute pulmonary emboli, more so for the hypotension than fever. Pancreatitis is a classic mimicker. It causes hypotension and a lot of third spacing. Fat emboli syndrome from long bone fractures, that presents with hypotension, fever, and what else? Happens with pulmonary emboli too. High Wycombe, what else? What happens to the platelet count? Drops down. So they have acute thrombocytopenia. The rest of these are a little obvious. The acute gastrointestinal hemorrhage is interesting. That's an important one to remember, because remember, if you have especially a patient with cirrhosis and varices with an acute hemorrhage, you can get a white count up to 20 or 30,000. And that's called a leukemoid reaction. That's not the same as an elevated white count from sepsis. Once the white count gets above 30,000, you're past sepsis. It could be sepsis, but there's more going on. That's such an enormously provocative stress that you'll often see nucleated red cells in the peripheral smear and so on. Those are called leukemoid reactions. C. diff can trigger that. Acute variceal hemorrhage will do that with hypotension, so everybody think, oh my God, it's sepsis. And then, of course, there's always the overzealous diuresis. It's always the fault of the ICU nurses, because they call around until they get the laces over. Transfusion reactions. The rest of these are fairly obvious, fairly uncommon. Adverse drug reactions are not uncommon, but we'll talk about that. So here's the microbiology of sepsis now in a community hospital, typical for us. Most common gram-positive coccidiosis strep pneumoniae, MRSA, MSSA. There's no difference probably in the virulence. It depends on the strain. What really matters is a little piece of DNA that determines whether it's invasive or not. And Ivanka Voyich, who's a microbiologist, PhD over in Bozeman, is, I'm not kidding you, believe it or not, she's on the cutting edge of the molecular genetics of what makes it invasive. She has a knockout strain of mice. She can make it invasive in mice that are made neutropenic. She can make this bacteria, MRSA, either cause cellulitis and an abscess, or make it cause bacteremia, or make it cause both. They've isolated the genetics of these. And MSSA has the same gene loci and can have that same invasive trait. Because 50% of the people that present with Staph aureus bacteremia, whether it's sensitive or not, have no obvious focus. They have a fever, they feel like they have the flu, and hopefully somebody draws a blood culture. And that can happen spontaneously. It's more common in diabetics, but it can happen to anybody at any age. Group A strep and Group B strep, Group G strep is increased. The thing that Group A strep, Group B strep, and Group G strep all have in common from the microlab report is that they are, and this is just a marker, it's not a virulence mechanism. Do you know what that is? Group A, Group B, and Group G. They're usually bathing in blood. So, on the blood artery plate, when that culture is set up, usually within 12 hours, is it 12, 18 hours, you'll see hemolysis around that. And that's a marker for an invasive strep or Staph aureus, which can do the same thing. Strep angiosis is a nasty little bugger. It's a microphilic strep. Comes usually from the oropharynx. I don't know if you guys remember, there was an infant here that developed an abscess in his or her neck. It was very young, just several months old, and John Kahn was here. And it was so necrotizing, pyogenic, it eroded into its carotid arteries. Do you remember that? That was like, this bug is incredibly invasive. And why people become bacteremic spontaneously, but sometimes it's from a tooth abscess or something like that. But it's very pyogenic like the other strep sometimes. And angiosis comes from the fact, that's the family name, that has a predilection to cause bacteremia, the angiosis meaning blood stream. blood vessel infection. That's where it came from. It likes anginosis is the predilection it has for it. Sometimes it comes from the gut. Sometimes it's involved in intra-abdominal diverticular abscesses and so on. But it has a propensity to cause metastatic infection. People can present with fever, elevated white count, low blood pressure, positive blood cultures. One gal came in that was a meth addict about 10 years ago, and she presented with a cerebral hemorrhage and endocarditis of the mitral valve that was so rapid and so aggressive that she died within hours of coming in. And her blood cultures all grew strepid and mucus. Probably that was from looking at the injector. It had to be an oral contaminant. Doesn't come out of the environment. So it's not a fomite. It doesn't come from surface transfer. Aerogram negatives are like E. coli, Klebsiella, other Enterobacteriaceae. And the thing that distinguishes these in terms of triggering a sepsis is that they have an endotoxin. We don't call it that anymore. We call it lipid A. It has a moiety on the cell wall that can trigger an inappropriate inflammatory response that can lead to sepsis. It's pretty rare for gram-positive anaerobes, Clostridium that are toxin-producing, Clostridium perfringens with gas gangrene. That's a pretty familiar and hopefully really rare. I've only seen one patient with that. That was back when I was a fellow. It was a gal that was living in a, believe it or not, living in a home. I'm not sure you can call it that. It was like a shack that had a dirt floor, and her toenails had grown so long they'd grown back into the bottom of her feet. And she got and when you have gas gangrene, usually by the time you get the surgeon to the bedside, they're often dead. I mean, that happens within hours. They're dead so fast. And draw the blood, and it's they spin it, and the serum is pink instead of yellow from hemolysis. That's usually more observational. And then rarely you see fusobacterium. We'll get a chance to talk about that. And then, so source control, key. With sinusitis, surgical decompression, that's pretty uncommon anymore. Clinically, that is really unusual for that to lead to sepsis if it's not decompressed. But with pneumonia, physiotherapy and suctioning, obviously, this is the most important complication of communicated pneumonia in terms of surgical intervention rapidly is not just drainage, but decortication. Sometimes we get it, sometimes we don't. Kind of depends on the enthusiasm of your surgeon. But really, the standard of care is to decorticate early, not later. That doesn't always happen, but that doesn't mean that's the right thing. I'm just telling you that. I'm trying to stir the shit now. You'll see different practices. Some surgeons aggressively intervene. Some don't. I'm in favor of aggressive intervention in this. Shortens hospital stay. Mediastinitis is obviously even more severe, so usually a complication of empyema. Sometimes in other hospitals that do more chest surgery, you'll see it as a complication of that sometimes. And you've got to drain, pus has to be drained. With peritonitis, that's another obvious sign. Clinically, it's not too hard, and you have to, resect, repair, or divert the sources of contamination. Cholangitis is important. We don't see so much of that because people are getting diagnosed faster as outpatients, but if you pass a stone and obstruct your common duct, you can die of sepsis if you don't, no matter what antibiotics you use, if you don't decompress that. Usually acutely it's with a cholecystostomy tube, but you've got to decompress the biliary tree. Same's true of the urinary tract. If there's obstruction and you can't get a catheter, and I think when I saw a septic patient last time with this, we had to get the radiologist, because we didn't have a urologist, do a suprapubic catheter. You've got to drain it. All the antibiotics in the world will not penetrate it if you have an obstructed bladder. You have to drain it if they're septic, absolutely. Catheter-related bacteremia, sometimes not usually sepsis, because these bugs are usually not as virulent. We'll talk about that. Especially aggressive, like staph endocarditis, will often require valve replacement. Septic arthritis requires joint drainage and debridement, not just once, but if it reaccumulates on the second day, you have to drain it again. Our orthopods are pretty good about opening and draining these and debriding them right away aggressively, so we don't see. Some hospitals have a lot of trouble. They'll tap it once and then they'll disappear and you can't get the orthopod back. We don't have that. We don't have that problem. Skin and soft tissue infection, debridement and necrotic tissue and drainage. What necrotic tissue and a soft tissue infection, what condition is that really important to your section? Come on, well, you can use the vernacular, the common name. Flesh-eating strep. This is a condition that requires immediate attention. And the only bad thing about the fact that we don't have any more Vietnam War surgeons, era surgeons on our staff is that general surgeons have become less and less aggressive. The farther away we get from our most recent battlefield experience, the harder it is to get surgeons to debride necrotic tissue or potential skin and soft necrotizing fasciitis, because sometimes you can't see it on the surface. It's just painful. But that's sometimes an issue of clinical debate. And obviously with prosthetic device infection, device removal, at least drainage is important. So what are the determinants of sepsis? What makes the whole thing go out of whack? This is just a cartoon. It talks about the influence of host defense, whether you're immunocompromised or not, in your B cells, and your T cells, and your macrophages, and PMNs. These cells, not so much B cells, but the T cells, especially macrophages, produce entities we now call cytokines. And with an inappropriate cytokine stimulus, you get consequences that lead to sepsis. The environment can contribute damaged tissue, predisposing conditions like cirrhosis. And then sometimes you're healthy, you don't have any problem with your host defense, you've washed your hands, you shower every day, you can still run into a virulent bug that'll be lethal. And the most common spontaneous community-acquired bug that causes death from sepsis is what? You guys know what that is? Just to put it in perspective. Strep pneumonia. It's still the #1 killer. Remember a few years ago, and it was in the summertime, so it's even more unusual. A 39-year-old guy came in septic shock and meningitis. I think he was dead within hours. He herniated and died. He was a normal, healthy host who ran into a bad bug. So strep pneumonia still kills. It kills people in their 30s and 40s. You're not protected because you shower every day and wash your hands and don't have diabetes. Strep pneumonia can be very serious. And sometimes the virulence is what predicates that. The serotype 3 is the most common, but some of that clinical evidence has been lost because it used to be more important or emphasized more than it is. But you can run into a bad strain of strep pneumonia that's as lethal as group A strep or MRSA. So let's talk about this one. To do some cases here. Wow, it's getting late. Holy smokes. Well, this is a 37-year-old lady, came with a 5-day history of fever, cough, dyspnea, pleuritic chest pain, no history of lung disease, no major medical illnesses, temp 104.6, hypotensive, tachycardic, tachypneic, hypoxemic. She had multifocal pneumonia, right lower lobe, right middle lobe, left lower lobe, large right pleural effusion, pH 7.12. What would the gram say in a sputum show? I just gave you the answer. Strep pneumonia, which is gram-positive diplococci, right? So they're like barbells on the gram stain. They don't look like grape clusters. That's what staph looks like. There. So what, besides strep pneumonia, what's the second most likely cause of CAP? Anybody have an idea? Depends where you are, right? Depends who the patient is. But who would it be in this case? What else could cause it? And septic shock at the same time. Klebsiella could do it. That's an encapsulated gram-negative. Not usually if you're not immunocompromised. On a healthy host, it might be Staph aureus, especially in the post-influenza season, especially with empyema. This is a marker for MRSA, actually, the rapid development rate. Denny Stevens, who was the ID doc down in Boise, who was the chairman of the Skin and Soft Tissue Treatment Guidelines for the IDSA and the College of the American Thoracic Society, collected MRSA isolates all around the country, from Johns Hopkins, UCLA, St. Pat's in Missoula, our hospital, some hospitals in the Midwest. And he looked at a marker called the PVL toxin, which some people thought at that time, may or may not still be true, was a marker for how virulent it was. And he had this table of all the isolates they had in the level of toxin production. And one isolate had twice as much toxin as any isolate anywhere, East Coast, West Coast, Midwest. That kid was from Whitehall, Montana. Like, we grew it out of his little food. He was 16 years old, otherwise healthy. He survived, but they can get so sick so fast. And this is with a bad bug, not a bad host. So what guides antibiotic choices? I think we can walk past this quickly. In somebody that sick, you want to reduce the bacterial burden as fast as you can. So the more bactericidal the antibiotic, the better for the patient and the outcome. But remember, in the first 24 to 48 hours, especially with septic shock, we haven't changed in 100 years the mortality rate of strep pneumonia with pneumococcal sepsis. We still, even with the right antibiotics improve mortality after 48 hours, but people are still dying in 24 to 48 hours because even though we kill the antibiotics, there's an excessive response of the cytokine system. Causes, we'll talk about it, all kinds of red rodent damage and stuff. That's why the pneumococcal vaccine's been pushed so hard. This was a gal I saw, I think it was the second year I was in Butte, 26, had a history, some unusual history of congenital dysplasia or agenesis, came in with a temp 104, hypotension, tachycardic, had a vague history of a respiratory tract infection, and she had purpura all over her body and the acral points of her body. So on the distal fingertips, the toes, the tips of her breast, the elbows. What does she have? Platelet counts 15 times. You guys know this. DIC. No, we're talking about the prostate. It's called purpura fulminans. But her fibrinogen was low. I didn't give you enough information for that. But basically, this is DIC. This is the worst form of DIC I've ever seen. She survived. She had a lobar pneumonia. What's the most likely cause of that in an asplenic patient? I hate to repeat it. It's important. I want to get this over and how important this bug is. Strep pneumonia. That's why you have to vaccinate every 5 years. That's why the Bozeman Hospital has an amazingly rigorous regimen for screening patients in the ER that have a fever. If you don't take a history of whether they have a splenectomy, because they got sued when they forgot to vaccinate the patient. It's a devastating condition that mandates a vaccination be very, very strictly adhered to. So here's a gal, another patient we saw here, woman who came in, we were told she had a perineal cellulitis from MRSA. It was positive, culture was positive from MRSA. She had a diffuse rash because she'd been given Bactrim, of course, for MRSA. Whether or not that there's been no clinical, there's never been a clinical study to show that that's better than anything else, but it gets used a lot everywhere, not just here. But it got used in her, right or wrong. I tend not to use it because when you get a rash, it's confusing. So because of the rash, they thought, well, she has a drug rash. So they started steroids. All right. The temp was 104, blood pressure 92 over 56, tachycardic, tachypnea, perineum was red and ulcerated. So is she septic? We don't have enough information to say it's septic shock. What kind of shock is this? This wasn't intuitive. It's confusing. It's what? Aseptic? No, it's not. It's actually turned out to be septic. Her blood culture became positive. We used to see that staphylococcal toxic shock. She didn't have a drug reaction at all. The rash was from toxic shock syndrome. So, and you think the steroids help? The blood cultures were positive. Her IV started hurting. She got a septic uveitis of her vein. They had to have her vein surgically resected. Her blood cultures were still positive. She got the first dose of Vanco she got, she went deaf in her left ear. What do you do? We had to use, at that time we had to use linezolid. That's the only other MRSA drug we had. What's wrong with linezolid for a patient who's got positive blood cultures in shock? It's not bactericidal, right? It's bacteriostatic. So that didn't work. And with the antibiotic removal mechanism in the blood culture bottles, her blood cultures were positive on nasal after 2 days, still. What do? You have to find another bactericidal antibiotic. Right? What else would you use? Can't use Vanco, she's deaf. You want to deafen her for life? Keep using Vanco. That's actually not a common side effect of Vanco, but it happened to her. What do we use? What's another bactericidal MRSA antibiotic? It drove the development of this drug. Cubicin, yeah, daptomycin. What's wrong with the choice of Dapto in this lady? You don't have it on here. She had septic emboli from her septic phlebitis, so it involved her lungs. So what precludes the use? What prevents you from using daptomycin? It isn't active. It has penetration. It's actually accumulated in the macrophages in the lung, but the surfactant in the lung inactivates the drug. So you can't use daptomycin in staphylococcal respiratory tract infection. So then we're really in trouble. Except that we happened to be doing the Taliban trials at the time. So we got compassionate use from the FDA, and she was treated successfully with Taliban, and we'll talk more about that in a couple of weeks. The choice of bactericidal antibiotics is really important in reversing septic shock. I'm going to move through this. Here's a couple of fever and hypotension patients. I'm going to go through quickly because I'd like you guys to have heard it once, because you never know when you're going to help somebody in the future. These are cryptic patients that come in, and we'll go through them quickly. 65-year-old man presents with fever, hypotension, tachycardia, no focal signs or symptoms. After 24 hours, temp still 104. He's on vancomycin and ceftriaxone. This was a guy who was an executive for a molasses international company that sold molasses to Coke. He grew up in Butte. He was back here visiting his friends, and he was in Finland. He was on the board of one of the Oakland City hospitals. What's wrong with this guy? He hadn't traveled anywhere, no travel history. He's shocky. We'd go through the usual looking for common sources of infection. I'm just going to let you guys see this, because this is sometimes, there's the problem the poor ER has. They don't get to follow a guy for 2 days. And sweating at 24 hours is tough. These are reasonable drugs to choose because you're treating MRSA here, and you're treating gram-negative infections like Neisseria meningitis or so on. So, what happened? What do you think happened? Wait. He developed later than, I think it was at 36 hours, where he'd had his coronary artery bypass vein graft. He developed a diffuse lymphangitis of his leg. So you can have a delayed appearance. If somebody has a history of previous lymphedema or lymphangitis, or a vein resection that interrupts the lymphatic flow, if they have local lymphedema, these people are really predisposed to gram-positive streptococcal staphylococcal infections. And the problem with some of them is that it often recurs. And there's a literature that says if it recurs more than twice, you should put them on prophylactic antibiotics for 6 months. So I told this guy that, and he went back and sat at the next board meeting, and his cardiac surgeon was sitting next to him. He said, "Oh, that doctor's full of bullshit." And of course, I'd given him the article. So he pulled it out of his pocket and gave it. So he eat shit and died. So was confident in the surgeons are. But that kind of delayed appearance, like the delayed appearance of pneumonia, it can happen in lymphangitis. You can come in septic and not have an obvious focus in the extremity. Usually it's the legs. But what you do have is a history of either previous lymphedema, or you see lymphedema without erythema, or you see just the scars from the vein donor sites. And that's enough to interrupt the lymphatics. That's such a serious impairment of the local immune response. If you run into the wrong bug, you can get very sick. This is a 32-year-old lady brought to the ER, confused, febrile, hypotensive, had no findings but a history, and this is a rare thing. But it's good to hear this once because hopefully you won't forget it. Only a little redness. What's missing in this history? I mean, what would you want to ask right away? What's that? The dog.
Yeah.
So a dog scratched her. So what's the next question? Why would you be vaccinated? She's 32. There's only one reason she'd be vaccinated. She had a splenectomy. Only vaccination is not going to help you here. This is just knowing this. So what do you ask micro to do while you start therapy for this patient? Hang on to the blood cultures for 2 weeks. Because this is a rare infection, and it's minimal. You'll just see a scratch from the dog, minimal erythema, but if they're asplenic, there's a rare but fatal condition caused by a bacteria called Capnocytopica. It used to be called DF2. If the ER doc, if you don't think of that, ER doctor, whoever's taking care of the ICU doesn't think of that and expand the spectrum to include coverage, usually with a beta-lactamase inhibitor, like Unicin or Zosyn. If you don't do that, if you just covered strep pneumo with ceftriaxone, for instance, you might not get adequate treatment. And this is a very fastidious, slow-growing bug. It can take up to 2 weeks to grow on blood culture. So you'd miss that. And the dog scratch is important. So an asplenic patient with any kind of dog has to be a dog. It's not cats, believe it or not. And here's an 80-year-old. This is a common problem. Brought the ER from the nursing home with confusion, fever, not hypotensive, but tachycardic. Chest X-ray is clear. No history is available. What do we do? What can you do quickly in the ER? This gets...
Urinalysis.
What's more important than the urinalysis? That's important. That's the first thing. What next? You see white cells in the urine. Do blood culture, but what do you do with the bladder? You want to know if she's in retention. And I know we just you scan. If they're obstructed, that is the most common cause is obstructive uropathy, especially more so in men than women. 56-year-old man, rheumatoid arthritis, presents with fever and hypotension, and he was on a TNF antagonist. What does that do to his immune system? Impairs it, but what does it make him vulnerable to? What unusual but not unheard of organism? Wild guess, somebody said used it earlier. Listeria. Yeah. They have an unusual vulnerability to listeria. Okay. So this is just another cartoon, and now, these are not overly profound. But the outcomes in sepsis really are dependent on how well or how overstimulated the pro-inflammatory system is, because that leads to cellular injury and multiple organ dysfunction. And these are, biological effects of these cytokines like tumor necrosis factor and IL-1 that lead to hypotension, not just the syndrome of sepsis. So fever, hypotension, you get induction of these interleukins, fibrolytic activity, elevated white count, increased endothelial permeability. And this injury occurs but isn't fully manifest sometimes for days. Stress hormone response, enhanced lipolysis, all those things are the biological effects. You get decreased oxygen extraction because the problems with capillary blood flow becomes irregular, and you get increased permeability, so the interstitial fluid increases, so the space across which O2 has to diffuse from the capillary to the tissue is increased, and so you get tissue hypoxemia. And this is just the cartoon for early goal-directed therapy. And this is something that most of you are familiar with. O2 intubation is necessary, mechanical ventilation, central line, sedation, and this is just the algorithm for the treatment of replacing a volume resuscitation with crystalloid or colloid, usually crystalloid here, and introduction of vasoactive agents if hypotension persists, and transfusion of red cells if the mixed venous O2 is still low, transfusion of red cells until the hematocrit is 30%. Otherwise, in the absence of that, sustained hypoxemia, you can tolerate a hemoglobin of 7 to 9 grams, even in sepsis. But if they start to show evidence of tissue hypoxemia, and we can talk more about that afterwards, then that would predicate getting the hemoglobin above 10 or the hematocrit above 30. And with persistent hypotension, sometimes you can add a hydrotropic agents we'll talk about. See, this is a dream that it would all happen in the ER. Most of the time, the ER has to move these people to the ICU and the lower half of this algorithm occurs upstairs. And these are just the parameters we use to follow organ function. Because we're running, I can't believe we're running short on time. I'm going to get right to this conclusion. Vasopressors and septic shock. So last year there was a prospective, multi-center, double-blind, randomized trial published in the New England Journal. Found no difference in 28-day mortality between dopamine and Levophed or norepinephrine in the treatment of shock. What they did see was more arrhythmia with dopamine. You know what the most common arrhythmia was? Connie, take a wild guess. She's yawning, I gotta ask her a question. Super SVT. Close. It's an SVT for sure, you're right. But it's irregular, so it was AFib. That's not intuitive. That was just what they, I'm just trying to wake you. And the dopamine-induced tachycardia was associated with increased ischemic events. And obviously, if there was underlying cardiogenic shock for any reason, there's a higher mortality rate with dopamine. And so the conclusion from that, which is sort of a current consensus, is that norepinephrine should be first in line. And after adequate volume resuscitation, this is an important predicate, at least 2 liters in most adults of normal size. If the norepinephrine or lead-treated patients still have a mean arterial blood pressure less than 65 to 70, to add a fixed dose, not a titrated, a fixed dose of vasopressin of 0.03 units. And if they remain hypotensive, that's within usually 8 hours or so, 6 to 8 hours, that's when they recommended the addition of IV hydrocortisone. That doesn't practice uniformly across the country, but this is, this is becoming a current sort of stronger emphasis in the last probably 6 months, 8 months. So how are we doing? We have time. So here's a 70-year-old guy who comes in with a abdominal pain. This is a patient we actually enrolled in one of our sepsis programs. Temp 102, blood pressure 70 over 40, tachycardic, tachypnea. He had a diverticular abscess with air fluid levels, and the radiologist drained it percutaneously, which is appropriate. His lactate was high, so he has septic shock, not just sepsis, right? He has end-organ changes, creatinine of 3, renal failure. On his 3rd day, he gets confused, short of breath, despite the use of a CPAP mask, and he's got a pH of 7.2, PCO2 of 38, PO2 of 84 on, high flow, 100%. Now he's got new bibasal and perihilar infiltrates. The radiologist says, this patient is developing pneumonia. What else could it be? Oh, come on. Yeah, just like the platelet count, which is probably at a bottom at this point, right? What is this? Is this hospital-acquired pneumonia? No. It's too soon.
Yeah. Aspiration.
Could have been, but it wasn't in this case. That's a good thought. Somebody said it. My hearing's so lousy. Somebody said, I think I heard ARD. I said, don't destroy the interest. All right, he's on higher than 50% FiO2. He's developing infiltrates. And this is what it is. Sometimes this is another patient with multi left upper, left lower, perihilar infiltrates. And this is what it looks like on site CT. The radiologist doesn't have the advantage of this clinical picture. You know it's the 3rd day. The radiologist doesn't know who this is, or they came from another hospital. You can't ask them to make that diagnosis. You have to put it into context. I'm going to talk just briefly about cortisol and sepsis, and this is, it's always hard to know when to apply it. The current algorithm says only in hypotension refractory to vasopressors, including vasopressin, now in the last 6 months. I kind of take it patient by patient, especially if they've had previous chronic prednisone therapy. I almost always cover them for stress steroids. I do always cover them. But the original observation was that patients with sepsis and trauma really initially had elevated cortisol levels. So why would you use cortisol? Well, this study was done in the late 90s, published in 2000. And they looked at patients in septic shock who had basal cortisol levels measured, and then they measured adrenal responsiveness with an ACTH challenge. And what they found was that patients in septic shock didn't respond well. they had a basal level to begin with that was less than the highest, the average level of 34. But they never increased their cortisol after ACTH by more than 9 micrograms per ml. So they had relative adrenal insufficiency. And that predicated the use of steroids empirically. And so just replacement stress doses. Pharmacologic doses of steroids were shown to not have no change on mortality. This was 10 years ago. And it increased the risk of nosocomial infection. So we quit using pharmacologic steroids about 10 years ago. But this was the study that predicated the use of stress steroids. And sometimes we use it sooner rather than later because we don't even do cortisol levels here anymore. So, it'd be 3 or 4 days in before you got your report. At least it was centricity. It's probably maybe there sooner, but I can't find it yet. So it leads to a lot of empirical. So what you ideally see recommended in literature and what you have to deal with locally is sometimes pretty different. And this is just a brief tip of the hat to Triogen, which is Zydrus. In severe refractory septic shock. And I only use these tables because this is the reason I don't use it very much. These are the inclusion criteria for the consideration of the use. And it's an activated protein C inhibitor. And this is the exclusion criteria. I don't know about you, but usually the patient's dead by the time you get done reading this and trying to get the history and figuring it out. So I use it rarely, and probably the reason I haven't used it much is because the last patient I gave it to had a spontaneous frontal lobe hemorrhage. And so hemorrhage is a big risk of Zydrus. A lot of it's personal predilection and experience, and I've tended to shy away from it. It probably has a place in patients with refractory severe shock, but it usually has to be initiated fairly early, and God help you. If you can get all this right, you'll probably be okay. So this is a surviving sepsis campaign that's been getting modified and will continue to get modified. You're all familiar with it. But it's goal-directed therapy in the first 6 hours. So obviously that requires initially you have to recognize a potential source of sepsis. The SIRS are the baseline, right? And then end organ changes. We went through all that. Blood cultures should be drawn. This is something that usually we do pretty well. Volume resuscitation is something we get criticized for, especially in the ER bites. And that's usually not because they don't know to volume resuscitate patients with sepsis, is because it's not recognized. So I think, and one of the best parameters I think that we underutilize the most in the ERs are arterial blood gases. We don't, I think we underorder them. They really help. The earliest sign of sepsis in a patient in the blood gas is what? Is there a therapist here? This guy. Is it respiratory alkalosis, respiratory acidosis? The first sign, alkalosis. You get tachypnea, blow off CO2, you get an acute respiratory alkalosis. If they have a mixed respiratory alkalosis and metabolic acidosis, they're septic. We'll talk about that a little more. Imaging studies to promptly confirm the source. Thank God for Nighthawk. Administration of broad-spectrum antibiotics. This is a tough criteria to meet within 1 hour of the diagnosis. We all have, every hospital has trouble meeting that. Very tough, because you've got to do all this before. Source control, after deciding whether they require a perforated bowel, for instance. You need open laparotomy. Is it localized off like a perforated divertic? Can you do a percutaneous drainage? Those decisions have to be made really fast. Vasopressor followed by stress steroids if volume resuscitation doesn't work. If they're intubated and require ventilation, low tidal volume, low peak pressures. With PEEP, if there's any evidence of acute lung injury, which is the predecessor to ARMS. And then targeted blood glucose. This is the one that's been, they had to back off of. Because originally they wanted the blood sugar between 70 and 100. And then there were too many deaths. Literally. They were killing too many people with hypoglycemia. And so that's been backed off to usually recommend, you'll see about 140, I say 140 to 180, because those glucometers have a 20% error. I'd rather have the nurse worrying about tissue perfusion and the other parameters we talked about than worrying about whether it's 140 or 160 or 180 for them. I think it's good to keep it under 200 because your neutrophils work better. But And then the bat prevention bug. Okay, last slide. This is one of those rare cases we talked about, where sepsis can complicate an upper respiratory tract infection. And if you're not familiar with this, and this blows by you, the death mortality rate's high. The girl in Belgrade, 17 years old, died 4 years ago from this. Kept going back in and back in without walking clinic, and it wasn't recognized fast enough. I don't think she even ever made it to an ER. Probably would have been picked up. She had a sore throat for 5 to 7 days, fever, swollen cervical lymph nodes, posterior cervical lymph nodes, muscle aches and pains. They do a rapid strep test, right, because she's got exudate in her pharynx, and they give her amoxicillin. She gets a diffuse macular rash. 100% of the time, if you give a patient like this, with this infection, amoxicillin, they get a rash. You know what? It's a viral infection. You know what it is? Mono. Epstein-Barr. Patients with mono, 80 to 90% of them colonize in the pharynx with group A strep. So you see a shaggy pharynx, and it's from the Epstein-Barr virus. Usually they're teenagers. Occurs in people under the age of 25 to 20 years old. Almost never above the age of 30. Right? You don't see mono above the age of 30 because we've all had it. May have been symptomatic, may not have been. You're not symptomatic if you're under 12. You're symptomatic if you're older than 12 or 13 when your immune system overreacts, okay? It's not an allergy to amoxicillin. It's a poorly understood biological effect of treating mono with amoxicillin. If that's the history of the only rash they had, they're not allergic to penicillin or amoxicillin. It's almost diagnostic, but you could do what test? Monospot, right? So you do a monospot and it's positive, and she says, oh, you've got mono, go home. Gave her some pain meds so she could swallow. She shows up 3 days later. Actually, the gal in Belgrade came in several times and was sort of treated conservatively. Best euphemism. She comes in 3 days later with temp 104, hypotensive, tachycardic, white count of 4,000, platelet count of 45,000. What does she have? Her blood cultures are drawn. Actually, there was a 20-year-old tech kid that had almost the same presentation that Pat McGree admitted, and his blood cultures were the same. What's the agent? It's an anaerobe that you don't see often. When you see it, you've got to recognize it. Wild guess, Pat? Fusobacterium necroform. This is something they call the Muir syndrome. Why is she, and it turns out that she's hypoxic, has multiple infiltrates, and looks on CT like she has septic emboli. They get a septic thrombophlebitis of the internal jugular vein. 2/3 of these patients probably have mono to begin with. This is a very unusual syndrome, but if you don't think about it, otherwise healthy people, you don't worry about exudative pharyngitis. If they come back in a second or third time, drawing of CBC is all you need to do to trigger, because by the time they're sick, if they're getting Lemierre's, they'll have either neutropenia and or thrombocytopenia. And they develop fusobacterium, and it's probably, people argue about whether group A strep has anything to do with it, but the EBV sets up the local immune compromise, and fusobacterium necroform is an anaerobe in the mouth that has a predilection to cause thrombophlebitis. Only one other bug does this. That's group G strep. They produce an agent that precipitates thrombosis of the local blood vessels. I was over in Bozeman talking to Brian Lansford a year ago, and he said, I got to talk to you about a patient I have with a liver abscess that has a portal vein thrombophlebitis. And I said, stop right there. I'll tell you what the bug you grew. It's fusobacterium. He said, how did you know? Because it's associated with local thrombophlebitis, septic thrombophlebitis. That bug has a great propensity to cause in the local, wherever it's causing the local infection, to precipitate a septic thrombophlebitis. So this gal's blood cultures and the patient Pat had admitted were both positive for fusobacterium necroform. What's tough about this case? That when you treat them, it's really amazing. Almost any antibiotic will work eventually, but they'll stay febrile with temps 100, 200, and 3 for a week. The blood cultures will still be positive, but because of the necrosis that occurs with that organism, they don't get better right away. This gal was in the ICU and developed MI